Good morning. Welcome to our MDA Engage Community Education Seminar. We're thrilled to have you join us live today, where we are highlighting specialists from the Northeast area with a focus around pediatric and young adult neuromuscular disease care. I am Elise Qualley, MDA's Director of Community Education and Chief Privacy Officer. We appreciate you joining us virtually, and we are glad to be able to share this important education seminar with you. MDA is committed to community education. We believe in the power of bringing our community together for opportunities to learn from specialists and having opportunities to connect with one another. This event is part of a larger MDA Engage series with disease-specific symposia, community education seminars, and community webinars as well. Our community education seminars, which is what we are having today, are geared towards general neuromuscular disease topics. While each features regional specialists covering a variety of topics, each event also features a specialty topic, which can be viewed on the screen. These are the events we have lined up for the remainder of 2020. As you can see, our last disease-specific symposia for the year is the SMA Symposia happening on November 14th. If you missed any events and would like to view the presentations, you can do so by visiting MDA Engage Archive Video section on mda.org. Some of you might remember our MDA Telethon. Well, we are very excited to be relaunching the legendary Jerry Lewis MDA Telethon with Kevin Hart joining us as host. The Telethon will be a 2-hour special airing globally on Saturday, October 24th at 8 p.m. Eastern Time. Hart will be joined by celebrity guests including Jack Black, Usain Bolt, Josh Glad, Michael B. Jordan, Eva Longoria, Jillian Mercado, and more. All funds received from the telethon will support the work that MDA does for the 43 neuromuscular diseases under our umbrella. To learn more about our big day, please visit thetelethon.org. We would not be able to put on our educational programming without the support of our generous sponsors. I would like to thank Numotion Foundation, Biogen, and Genentech for supporting this seminar today. I would also like to thank their representatives who are in attendance today. Now, before we get going with our presentations, I do have a few housekeeping items to go over. We are recording today's event, and we will be posting this event to mda.org for on-demand viewing in a few weeks, and to ensure that those who were not able to join us live today are able to access this information. For those of you joining the live event, please do know that all phone lines have been muted. We will be having a Q&A session at the end of each presentation. So please utilize the Q&A icon to type in your questions. If you hover over the bottom of your screen, a tray of webinar icons will appear. Click on the Q&A icon to open the feature, and you can enter your question. You don't need to wait until presentations are over to submit your questions. As questions come up during the presentation, please feel free to type those in and send them in, and we will plan to get to and answer as many of those questions as possible. We also encourage attendees to communicate with other participants by utilizing the chat feature throughout the day. Want to say hi and let attendees know where you're from? Want to share a bit of your story with others? Or would you like to obtain some suggestions from other community members? Please use the chat feature to do so. To do that, simply click on the chat icon at the bottom of your screen and make sure to chat to all panelists and attendees. Feel free to utilize this throughout the day to connect with others. Now on this slide, you can see the agenda for today, and you'll notice that there are some small breaks between speakers. Please feel free to stay connected to the live broadcast during these times, but this will also allow you time to grab some water or a bite to eat throughout the day. During this time, we will be checking audio for our next presenters, so you may hear us chatting a little bit between presentations. Finally, we will be sending out a brief survey afterwards, and we would like to receive your feedback on what you heard today in this event. We want to make sure we are discussing topics that are of interest, and we use your feedback as ways to improve our educational events and programming. So thank you in advance for taking 5 to 10 minutes to complete the survey post-event. I will share a link at the end of the event, as well as send out an email that will have that survey. So now that we've wrapped up kind of all the housekeeping items, I am thrilled to have Dr. Leslie Delfiner on the line with us today. Dr. Delfiner has been wonderful to work with on this event. She has chaired this event and helped us with building out the content, securing all of the presentations you're going to be hearing today. So we're thrilled to have her on the line. I'd like to give you all a brief introduction to Dr. Delfiner before I turn the presentation over to her. Dr. Delfiner is a child neurologist with subspecialty training in neuromuscular and electrodiagnostic medicine. A graduate of the Weill Cornell Medical College of Cornell University, she received postgraduate residence training in pediatrics at the Mount Sinai School of Medicine in New York City. Dr. Delfiner then completed her neurology training at the Albert Einstein College of Medicine, where she now serves as assistant professor in the Isabel Rapine Division of Child Neurology and the Saul R. Corey Department of Neurology. As co-director of the MDA Care Center at Montefiore, Dr. Delfiner cares for children and adults affected by all forms of muscular dystrophy. She is committed to providing patient and family-centered care in a supportive atmosphere and environment. Dr. Delfiner has a special interest in building individualized support systems for patients and families who have been diagnosed with neuromuscular disorders, especially building patient-specific care plans in the multidisciplinary setting. And so with that introduction, Dr. Delfiner, are you able to unmute and share your slides? I'm going to go ahead and just pause the presentation and see if you can do that.
Sure. Good morning. I'm just going to pop up my slide deck here. Good morning. Elise, are you able to hear and see me?
I cannot see you, so if you could turn your camera on, that would be fantastic, but I can see your slides.
Okay.
All right, there you go. Go ahead, take it away.
Good morning, everyone. Thank you so much for taking the time to join us on such an early Saturday morning. My name is Leslie Delfiner. Thank you for the introduction. Today, we're going to be spending a little bit of time talking about what it means to have a best practice in care as a family affected by neuromuscular disease, either as a child or as an adult. The goal of today is to walk you through different areas in care plans and see not only what does it mean to come to the clinic and see a cardiologist or a geneticist or an orthopedist or a neurologist, but how can you yourself prepare to get the most out of your visits, and how can you engage in your care as a patient or family to make sure that you are receiving best practices, both for whatever your specific muscle or nerve condition is, and for you as an individual person with unique needs. So today we're going to talk about what is a best practice. We'll talk about building an approach to your own care center visits, building an approach to your home life planning, ways to maximize communication with your own care team, and we'll hit on briefly the concept of transitioning to adulthood, which is a big, scary topic, but better to talk about earlier than late. So what is a best practice? The goal of a best practice, and I'm using air quotes there, is to create effective systems within the healthcare space to achieve the best outcome for you. A best practice can be based on a guideline for your specific neuromuscular disorder, opinions of experts in the field when we're talking about very, very rare disorders, natural history, stuff we already know about a certain problem. It serves as an outline, a roadmap to care, but it's not a direct recipe book. Best practices help inform patients and families of what the understood guidelines for care may be for a specific disorder. They allow for greater access to multidisciplinary care by encouraging the multidisciplinary model. They maximize patient education, and ideally best practices improve communication throughout a care team. Best practices do not prescribe a single pathway of care for every single patient. They do not replace clinical judgment of the physicians and ancillary healthcare providers on your team or parents. They do not replace patient-based and family-based goal setting. Every child, every adult is different, and we need to honor and respect and value that. So for some basic background, I encourage you to spend a little bit of time looking around the MDA's website. The Grand Rounds videos are available for everyone to view on the MDA website and help you prepare for what you can expect once you engage in life in the neuromuscular realm. This video particularly, I think, is worth your time if you don't mind wandering over to mda.org. Best practices apply to doctors, to physical therapists, to dietitians, and to families. Right now, I'd like to talk a little bit about what we see as clinicians on our side as best practices. So when your doctors are becoming experienced in the management of a certain condition, they may go online to the medical literature and look for care guidelines or examples of best practice documents. That might be a specific guideline pathway. Here I've given you two examples of or three examples of care guidelines that have been published for the management of Duchenne muscular dystrophy. These are documents that have been published in the medical literature that are based on evidence and expert recommendations of physicians in the field that help provide a playbook for what we would expect for the care of any patient with Duchenne muscular dystrophy who's going to be coming into an MDA care center or may be receiving care in a part of the country that does not have easy access to MDA care. If we don't have specific guidelines, there may be consensus statements where a bunch of doctors who are recognized experts in the room, who are research experts, and who have experience treating the disease state may come together, review the available literature and evidence, and make recommendations that outline similarly a pathway to care, almost like a guideline. This is an example of what we have available for the management of myasthenia gravis. When you're coming into an MDA care center, you can feel confident that your clinicians have been aware and engaged in these guideline bases of care. Best practices might include specific pathways. For example, how do you decide to start steroids on a patient with Duchenne muscular dystrophy? What do you need to watch out for when making that decision? What type of education do you need to provide? Again, a playbook, not a specific recipe, and every child is different. But pathways like this help clinicians frame their thinking so that they can come to you as a family and as a patient to make the best possible recommendation and discuss risks, benefits, and realistic expectations with you. So not every disorder has a care guideline. In the MDA community, we know better than anybody else, you as families, we as doctors, and the MDA team members, that some of these disorders are very, very, very rare. But there can still be a best practice even if there isn't a published statement. There can be expert consensus, clinical experience of your MDA clinicians, both within your center and in the broader MDA space, because we as MDA clinicians do speak with each other at care director meetings and at national conferences via email and over the phone. And then there's also support and guidance available from disorder-specific organizations. For example, the Jane Foundation provides guidelines that work together with the MDA. All of these organizations work with families. The Muscular Dystrophy Association provides the broadest umbrella for support and care. But when you come to an MDA care center, you can be confident that if there is clinical data or best practice guidance for your specific disorder that helps provide care for patients, even if it is provided by a different organization, it would never be withheld or deprived. When you come to an MDA care center, all of the best practices are available to you. But what about best practices in the more global sense? A best practice doesn't just mean that we're checking off boxes on a checklist. There are also best practices for family and clinician teams together. In my mind, that means developing a diagnostic plan and a goal that includes counseling and education for each individual patient. That will depend on a patient's age, a patient's family structure, a patient's goals for their own life, a patient's developmental level. It means following up on schedule. So depending on your specific situation, sitting down with your care team and saying, I need to be seen once a year, or I need to be seen twice a year, or I need to be seen 4 times a year, and having an expectation of how often you'll be checking in with each other. This is particularly important in the time of COVID, when we've shifted away from our standard clinical practices and become a little bit more flexible and fluid. Maybe some visits will be telehealth, maybe some visits will be in person, but knowing how often you need to be checking in with your doctor in some form, knowing that ahead of time so you can plan life, is valuable. Having access to a multidisciplinary team is important, but there is no one way to do that. Part of the goal of today is to introduce to you our model here at Montefiore so that you can learn from the way we have tried to build bridges and move mountains. We have examples of in-center multidisciplinary care with our care team, where children and adults can receive care from rehabilitation medicine and neurology and cardiology and pulmonology on the same day and in coordinated fashion, and that's wonderful. But we also have examples of close-knit relationships and coordinated care with our colleagues in other specialties who patients are not able to see on the same day. It does not present a barrier to care when you're able to plan ahead and coordinate your approach to providing care to a family. And so we'd like to show you examples of both of that today. As we know, in many parts of the country, the appropriate model and the best model for certain MDA care centers is having multidisciplinary visits on separate days. And that can work very well as well. Access to social work resources and genetic counseling resources is crucial. And of course, access to subspecialists who have knowledge and expertise in the very unique management of neuromuscular disorders. And then finally, either access to clinical trials or confidence that your center would refer you to an appropriate clinical trial site if an opportunity were to arise. And that means engagement of the family with the clinical team. I normally, if this was in person, would ask if anybody has experience with the MDA clinical trials tracker, but I'm just going to talk about it here for a moment. When you come into your MDA care center, the best practice for finding appropriate clinical trials ideally would be the clinical team talking to you about trial opportunities, but you also knowing about the MDA clinical trials tracker, which is a great part of the website where you can enter information by clicking boxes on your child or yourself and see if there's anything of interest that might apply to you. You could click that you have spinal muscular atrophy. You could put the zip code that you live in. You could put how far you are willing to travel, how old you are, and a little bit about your medical background. And the MDA clinical trials tracker will actually print out a list for you of potential trials that might apply that you could then bring to your visit and ask questions about to your clinician. So how do we build an approach to your care center visit? The clinical plan and your own family needs need to dictate the schedule. So for example, at this point in time, what subspecialty care is needed? For example, do you need cardiology, pulmonology, and rehab medicine? Or do you really just need to see your neurologist and the cardiologist at this point in time? We can prevent over-medicalization of families by making sure we're following care pathways based on your point in your journey with neuromuscular disease. And at the same time, we can prevent underutilization of necessary medical resources, making sure you're not missing out on what you need by following that pathway as well. For each visit, there needs to be a thought or a discussion of, is this going to be an in-center process? Can we achieve everything in-center that day? Or are we going to need a coordinated itinerary? For example, will Johnny need specialized testing with a certain radiology department that's not going to happen on the same day of the clinic visit? Can we coordinate that ahead of time in a way that is convenient for your family? Think ahead of time what education is needed. If you're a family who is providing steroids to yourself or to your child, have you had your important steroid safety training? Have we had a chance to talk about implications for family planning, either for you as parents having future children, getting your family members who may be at risk screened before they have children, or starting to talk about family planning with young adults or other young families who are in those fruitful years, so to speak? And are there going to be any social work needs today? Do you need a quick check-in with the social worker for an insurance question? Do we need to talk about counseling resources? Do we need to talk about safe housing and accessible housing solutions? The endpoints are to select a care center date with the key services available to you, or dates if your center is using a multi-day model. Let's talk about preparing for a care center visit. This is something that I think is quite important. I like to think of your MDA care center as a family event or a patient event. It's something on your calendar, and just as much as your MDA care center team is planning for you to come, making your schedule for the day, reviewing your chart ahead of time, looking for trials, you as a family can also prepare so that you get the absolute most out of your chunk of time with us. So things to prepare ahead of time. Do you have a binder or a folder where you can keep your MDA materials together? Think ahead of what you might need when you come in for that day. Do you need an updated contact sheet for your MDA care center? For example, at our care center, we had a shift in our care coordinator. We had to create a new contact sheet with information and the name of the person who was the point of contact for scheduling. And we presented that to patients at their follow-up visits. If you've noticed a shift in the care team, maybe you can ask for that to make sure that it doesn't get missed. Do you need an updated emergency letter? At our center, we provide emergency letters for use for our patients to bring to emergency rooms and show to other physicians while they're waiting to get in touch with us. For example, a patient with Duchenne muscular dystrophy will have a different letter than a patient with myasthenia gravis, which is a different letter than somebody with spinal muscular atrophy or a congenital myopathy or Charcot-Marie-Tooth disease. These letters have quick information for how to contact your MDA care team, for emergency information, things that a doctor who may not be experienced with these rare disorders needs to know for the first few minutes in the emergency room while they're trying to get in touch with your care team. Have you had one of those updated in a while? At our care center, we try to update them every year or if something changes. But if you notice that you haven't had one in a while, it's good to ask. Make a list of questions ahead of time so that we can be efficient in the office and address all of your needs. Do you have any new equipment needs? Is something broken on your wheelchair? Have you noticed that your bath chair isn't supporting you as much as you need and you might need a sliding bench? Is the seatbelt on your chair broken? Let us know ahead of time or bring the list to your visit so that we can be prepared to handle it. And most importantly, well, sort of importantly, do you remember where your wheelchair weight sticker is? Ideally, if you are a person who uses a wheelchair for mobility and assistance, there will be some notification of how much your wheelchair weighs so that when you come into clinic, we can easily weigh you and then subtract the weight of the wheelchair without having to worry about transfers multiple times throughout the clinic visit, which I know is frustrating and uncomfortable for some families. We can just do the transfer once. It's okay if you don't have a wheelchair weight, but next time you're there, ask for one. It makes life a little bit easier for follow-up visits. Please bring with you outside reports. If your family opts to follow a specialist closer to your home, say for example, you're seeing your neurologist in your MDA care center, but you were coming from 2 or 3 hours away and know that you need a pulmonologist who is closer to home because of frequent follow-up needs. If you're seeing that separate pulmonologist, bring a copy of the note or at least call the care center ahead of time and make sure that it was faxed to us by the physician. Bring copies of your updated vaccine records, any school reports that might be relevant, paperwork that you'd like us to have fill out, either for accessible driving placards, parking placards, SSD paperwork, anything that you feel we can help with, or FMLA, Family Medical Leave Act paperwork. These are things we can help with. And of course, contact information for your primary care physician. Best practices in primary care planning. This really does differ based on patient and type of disorder. Everybody should have a bus driver. And in many cases, The bus driver in neuromuscular care is a combination of the family and the neuromuscular physician at your MDA care center. But your pediatrician or your internist or your primary care physician for your family serves in that role as well. And the partnership between your MDA care center and your pediatrician or primary care provider is a beautiful partnership that can empower your family. There should be good communication between your care center team and your PCP. Does your pediatrician know if you are one of the patients who would benefit from getting an extra pneumococcal vaccine? Does your pediatrician know how often you'll be seeing your neuromuscular specialist? If lab work is being done at your MDA care center, is that being shared with your primary care doctor to optimize your general health? Pediatricians and PCPs can have access to the same care guidelines that we have in the MDA care center so that we're all following the same roadmap. Reliable sharing of coordinated notes is helpful so that when you go to your pediatrician, you don't have to say, well, I think they said, and when you go to your MDA care center, you have to say, I think my pediatrician said. It helps take the burden off of you if those notes are accessible to everyone. You can either ask to have them faxed or mailed, or you can ask for them when you see your doctor and just put them in your binder to bring between visits. This carries over into the same theme of how can we make care safer and more efficient. It moves us on into this idea of best practices in emergency planning. We don't like to think about the possibility of emergencies happening, but at the end of the day, families affected by neuromuscular disorders are families just like anyone else, and bad luck happens. Even though my hope is that we would never need to use an emergency letter, people break legs, people have accidents, people break teeth, or there's a risk of decompensation or getting really sick related to your neuromuscular disorder. In a moment of stress, the idea of an emergency planning letter and an emergency plan is to give you the tools you need to focus on getting help and not focus or scramble on trying to figure out how to educate emergency room providers about your rare disorder. Again, an emergency plan is going to vary based on patient and disorder. The goal is to improve safety and minimize stress. So here at our center, we think the key components of an emergency plan are an emergency letter. This could be something as simple as saying, Johnny has named the disease. Please contact Dr. Delfiner or the on-call physician at. It may have contact information for the cardiologist or the pulmonologist or the endocrinologist if those are really emergency level people for that specific patient. And we'll probably have a few key warnings. For example, may say this patient is at risk for malignant hyperthermia, complication from anesthesia. Please use a caution should the need for anesthesia arise. Or a patient with spinal muscular atrophy may have a letter saying, this patient is at risk for hypoventilation. Supplemental oxygen should not be supplied. If there is a need for oxygen, please utilize ventilation at the same time. Everybody's letter is a little bit different, but the idea is for it to be a short letter that says, how do I keep this patient safe while I'm waiting to get in touch with the right people who can help? And what do I need to know about this pretty rare disorder? That takes the pressure off of you as a patient or as a parent or as a family member so that you don't need to be in that moment the bus driver. You hand over the right information and get things moving. We recommend that families take a picture on their cell phones of their emergency letter, because you might not find the paper, but you'll always have your phone with you. Or take a copy of it, put it in a laminated envelope, and stick it someplace where it's easy for you to have. That might be stuck to the bottom of the wheelchair in an envelope. That might be in your purse. That might be folded up in your wallet. Lots of different options. Having an updated medication list is really good for anybody, not just somebody affected by muscle or nerve disease. So anybody who's watching this talk, it may not be somebody who is affected by muscle disease themselves. That's good for you to have at all times as well. Know if you are someone who needs special anesthesia precautions. Certain neuromuscular disorders require avoidance of certain anesthetics. That is something that would have been discussed with you in your multidisciplinary center if it applies to you. But if you are at risk for having either muscle breakdown, rhabdomyolysis, or malignant hyperthermia, a dangerous reaction to certain types of anesthesia, that's something you should know to say. And maybe, depending on your situation, may be worth having an emergency medical alert bracelet. Talk to your doctors about it. And then finally, for people who live in smaller communities, who have volunteer ambulance corps or town-specific ambulance corps, it's a good idea to have some point of contact at your local emergency medical response team. For example, if you're living in a small town that has its own ambulance corps, if you have a child or you yourself are a patient who has a rare disorder that needs special emergency care or awareness of special emergency issues, it's reasonable to have a copy of your emergency letter or a letter of introduction sent over by your medical doctor, or even giving them a call yourself and saying, "Hi, my name is Leslie. I have X disease. I hope that I never need your help, but if I do, here's what I'd like you to know about me." For families who live in very large apartment complexes without reliable elevators, which is a sad truth and reality for some families, it's important to let your apartment management complex know that you might need help getting out if there was ever an emergency, and let the local fire department know to check on you if there was ever an emergency in the building. These are things that sound scary. They sound like one more thing to worry about, but will also provide peace of mind and remove the burden, knowing that you have all of these steps in place so that they can spring into action if they were ever needed, which they hopefully won't be. Let's take a moment to talk about methods to maximize communication, which in my opinion is the most important best practice in care. Please make sure you always know how to call your care center. What is their phone number, their fax number, and how do you access your information electronically if that is an option for you and if you're interested. Some families love it, some families do not, but if you're one of them who likes it, know how to do it. Make sure that if your contact information changes, tell your care center. We might be trying to reach you with either a need to see you for follow-up, an update in care plan, sending you a letter about relevant information to you, but if you don't tell us that you've moved, we can't find you. Remember to bring questions with you to your follow-up visits and request a timeline for expected next steps. When you leave your visit, you should know when you're coming back and what needs to be achieved in the interval. Ask your doctor. I was told that I should be called with an appointment for an EMG, like a muscle and nerve test, before the next visit. How long should I wait before calling you to tell you that I haven't gotten an appointment call about that? These are ways to make sure that when you come back for your next visit, you don't feel that time has been wasted. Review a list of reasons to seek medical attention with your doctor. For your unique disorder, what should you worry about? And finally, sign any medical release forms that might be needed while you're in the office to save yourself a trip to Kinko's. We know that it's hard to come into the center, but if we want to request notes or information from other facilities that may have provided service to you, or if we want to share information, if we were not, and this applies to any care center, if the doctor who you're seeing on a given day was not the referring provider or is not already in a consultation relationship with another facility about you, you will need to provide medical release for us to request information or send information. When you check into your care center, ask, are there any release forms that you need to sign that day so that we can start tracking down things on your behalf? And don't forget the value of a single clinician visit when appropriate. If you have a disorder and you're all up to date on your care, but you have a new issue, my braces are hurting, I need to see my rehab doctor. Or, I know this sounds random, but I think I've developed carpal tunnel syndrome. Maybe you just need to see your rehab doctor or your neurologist that day. Talk to your care center about the possibility of either telehealth or in-center visits just with a single clinician if the need should arise. Coming to MDA doesn't necessarily mean an 8-hour journey every time. Sometimes you can come in and out for a regular doctor's appointment too. Transitioning to adulthood. It begins far before age 18. Medical preparedness is an ongoing conversation. Many patients within the MDA community are ready to take over their own care as they approach adulthood. Other children who may have developmental issues beyond just their muscle strength may need help going forward and the support of their families. But these are things we need to talk about early on. So as you approach age 18, when you're coming into your care center, we might be talking about, what do you need to know about your disorder? Can you say the name of what your muscle problem is? And what is your muscle problem? What does it affect? What problems does it cause? Do you know the names of your medications? And do you know how to refill your medications? When your pills are running low, how far in advance do you need to call for a refill? When do you call your pharmacy for the refill? When do you call your doctor? Do I know when to get help? Do I know how often I'm supposed to see my doctor? And when will I meet my new physician team if I'm outgrowing my pediatric MDA care center and moving into an adult MDA care center? This is too much to talk about in a single visit. It's overwhelming for patients, and boy, is it overwhelming for parents, because we don't like to think about our children leaving the nest. We start talking about this as early as age 14 to start introducing independence and ownership slowly over time. And then, important for any young adult, things about actual independence in terms of paperwork and life stuff. How do I stay enrolled in insurance? Who should I bring with me to visits? These are not issues that affect only people with neuromuscular disorders. I would be surprised if most 18 or 21-year-olds know how to enroll and handle their own insurance. But because you have the advantage of participating in an MDA care center, you can prepare for things over time and get ready so that when it's time to reach adulthood, when it's time to take on your independent role as your own care decision maker, you have the tools you need. And then finally, life preparedness. What comes after high school? We are excited for our young patients in the MDA community to reach their dreams, go on to college or to trade school or volunteerism, become engineers, professors. YouTubers seems to be kind of the new thing that people want to be. But the future is coming at you. And these are things we can talk about in the MDA care setting as well. Are you getting the educational supports that you need in school to help you reach your dreams? Are you receiving the guidance counselor supports to make sure that you are on track to apply to the colleges that are right for you, if that is what you want for yourself? And finally, when you're seeking your first job, when you are seeking your college experience, how can we make sure we are advocating to make sure that your specific disability needs, either mobility needs or breaks or assistance in the office space or wide open doorways, how can we make sure that all of the things that are supposed to be available to you to help you reach your goals are? We can talk about that in MDA, and I'm so excited that there's going to be a session later on in the day addressing this specifically. So who can help you? Your care center physicians, your social work team members, your pediatrician, or your adolescent medicine doctor if you've been transitioned into one of those. Your MDA team representatives. We know that the MDA has restructured a little bit, but your MDA team is still there and raring to help you. And there are so many resources available online and if you call in. School counselors, teachers, and then of course for children with additional needs, educational advocacy, and family lawyers. Some children, MDA or not MDA, due to developmental issues, learning issues, cognitive issues, may not have the ability to go on and take on their own medical ownership in the future. Your care team and your pediatrician can help you decide if that's right for you and what process needs to go into the thinking about medical guardianship and legal guardianship and custody for children who may have more cognitive needs and developmental disabilities. So preparing for your first adult visit. What should you bring? Bring that care binder or folder that we talked about. In our care center, we encourage people to use whatever they think they're not going to lose. So for some families, that's a notebook that they write in. Other families, that's a single folder where they stuff in papers. And other families have a binder organized by section. But whatever you're using, bring it. Confirm that your records were sent ahead of time. Bring copies of what your usual emergency plan was, because your new care team, once you start making that transition, can build off of that. Bring your contact info, bring your PCP's info, and bring your pediatric MDA team's info as well. They will have been the ones to help you make that transition, so it should already be there. In our center, we do operate once per week on a lifespan basis, and we slowly transition from the pediatric MDA doctor to the adult MDA doctor, but other centers actually have separate physical spaces and days. And so you should talk about that ahead of time and plan. When you get there, ask for the new contact sheet, ask for a new schedule of planned visits, sign new release of information forms, and ask for recommendations of where to go for help. Meaning, who is the new social worker? Is it the same person you've worked with, or is there somebody new you need to be introduced to? And of course, ask for an updated emergency letter or plan. So in the end, best practices are a guide, a set of goals, and they outline a pathway, but the specific journey The specific roads and highways that you take as a patient or as a family are going to depend on your child or yourself. Best practices do not replace individualized care. You should be proud that your care is unique, informed by best practices, informed by guidelines, but unique to you. The best practice is to continually work towards a system that provides the best outcome for you as a person and helps you reach your goals and optimizes your health and abilities. So here at Montefiore, this is our care center team. The saying that it takes a village doesn't really apply to the MDA. It really does take a city or a district. We have members of our Department of Cardiology and Pulmonology, Gastroenterology, Orthopedics, Physical Medicine and Rehabilitation, our Quality Impact and Life team, which is a palliative team that helps us cope with chronic illness and explore ways to maximize quality of life and joy, social work, genetics, neurology. It seems that my physical therapy, dietitian, and endocrinology teams have fallen off of this slide because it was such a long slide, the city couldn't even always fit, I suppose. Rehabilitation, speech pathology. We all work together. And anytime you enter the MDA space, know that you have a team of hundreds of people who are rooting for you, a team of hundreds of people whose only goal is to help you live your best life, gain access to care, and optimize your health while we wait for better treatments and eventually cures, because they're coming. We are so hopeful for your bright future. And I hope that by following these best practices, we can help get you there. Thank you.
All right. Thank you so much, Dr. Delfiner, for that presentation. Wonderful. Well, we're going to go ahead now, and we've got about 10 minutes open here on the line that we can take some questions from attendees. If folks have any questions for Dr. Delfiner, please go ahead and at the bottom of your screen, if you're on a smart device, I believe it's still at the bottom of your screen, you can hover over and there is a Q&A box. If you click on that, go ahead and type in any questions that you may have in there, and we can get through kind of as many as possible. And while folks kind of get in there, Dr. Delfiner, I appreciated that you put in the information on contacting your local EMS as just a best practice. I know from some local families down here that that's important to them. I know when we were in person at our camps, that was also very important to us, that they just knew who we are and you know, where we were. You know, do you have recommendations for families on kind of doing that outreach? Is it to stop by your local EMS station? Is it to give them a call? What have you seen work?
So a lot of this depends on where you live. So in the New York City area, we have a massive EMS command station, and you cannot be guaranteed that your local fire station or your local hospital will be the one to dispatch to you. And so if that is the case, what we actually recommend is just having your emergency plan set to go. And as soon as EMS arrives at your house, you show them that letter. But you live in a smaller town or someplace that does their own dispatching, what we recommend is giving a call over to either the ambulance corps, your police station, or your firehouse. You can call any of them and ask them how you can be put in contact for whoever the chief is for emergency response services for medical issues. Sometimes that's going to be a sergeant or somebody with that type of title, or a captain within the ambulance corps. And other times it's going to be a physician from a local hospital who serves as a medical director. And what I recommend is calling and asking to speak to that person and saying, hey, my name is Leslie. I live over on Sprain Street, for example, and I have a rare disorder. I have an emergency care plan in place, and I just want to make sure your team knows about me so that if they ever get called, can my doctor send you a letter, or would you like to speak to my doctor? And different teams are going to feel differently. For really small towns, I have had one-on-one conversations with the team. For bigger towns, it's just I faxed a copy, not the emergency letter per se, because I always worry that if something changes and we don't make sure that everybody gets that updated letter, somebody could have outlined outdated care. But I'll sometimes just send a letter saying, hey, here's my number, and here's the name of the disorder. It's a little bit of a peace of mind. The smaller the town, the more likely it is that whoever shows up your house is going to know who you are. But even if it's somebody who you don't know, you'll have that emergency letter and they'll know how to start getting you someplace safely.
Perfect, perfect. And I think too, you touched on it, and just want to put a plug in. I know you're also working with us on some educational materials. We're hoping we can leverage kind of the emergency letters that you all have kind of been using, and kind of transition them into some disease-specific laminated type cards that folks can put in their wallet to take with them should they be in an emergency situation. So we're looking forward to having a couple of those available yet this year, and then kind of expanding on with other diagnoses for next year. So thank you for kind of sharing that wisdom that you all have learned, and I think we've heard in different disease spaces at how vital that those can be to help people in crisis times. Perfect. So I think one of the other questions that that kind of we hear a lot about that come in is around those diagnoses that have care guidelines, and I know you spoke about them. How familiar do you recommend families should be with them? Because I think we hear that often too, that, you know, a lot of times they can be fairly medical, the care guidelines, and families really are relying on their medical professionals to do that. But I know you mentioned kind of also, you know, being aware of what's in the guidelines. So where is that balance? Do you recommend families do go in and read all of those for those that are available?
I think that everything depends on the family, and the patient. Reading those care guidelines can be incredibly overwhelming, and quite honestly, not every person is going to need or receive or best be served by everything in that care guideline. Sometimes it makes a little bit more sense to use a more patient-centered and patient-intended document. And so by going onto the MDA's website and looking in the patient education materials, there are overviews and summaries of different disease states, and they talk about the different things you need to worry about. So if we use Duchenne muscular dystrophy as an example, it would talk about the heart. It would talk about the lungs. And you can use that as a checklist. And instead of digging through the care guideline and saying, did I start the exact name of the medicine that they mentioned, and did I start it at 10 instead of 10 and a half years old, and I don't know, you could just come in with a checklist and say, hey doc, can we talk about my heart? Hey doc, can we talk about my lungs? Am I getting the things that you would give as a standard, or am I getting more of a unique care plan? The MDA works beautifully with other organizations who provide useful information. And as families, by coming to an MDA care center, and I truly mean this, by coming to a center that has a label on MDA, it does not mean only MDA. And so nobody would ever be bothered or worried or feel insulted if you came in with a document provided by an organization that focuses just on your disease state. So for example, and I'm not going to talk about different family organizations, there are community organizations specifically for Duchenne and spinal muscular atrophy and the congenital muscular dystrophies and congenital myopathies, and they provide patient booklets for your disease. You can always bring those in because they're meant for families and doctors and go through them. Nobody would ever expect only MDA materials to be discussed in an MDA care center, because the goal of the MDA is to empower all patients with neuromuscular disease to receive the best possible care. And that means using all resources available within the community.
Yeah, I think that's a very good point. And I think I see in here we got a comment in, which I think is an important comment, and one that we do hear for some of our diagnoses, especially those that may not have treatments available. And it was around just someone who is currently in their 50s, but they really stopped going to MDA in 9th grade. What advice would you give to someone in that situation who maybe hasn't been seen at a care center in some time?
So there's so many benefits to coming to care center, but I also understand, I've had people say to me, doc, I come, you tell me I look okay or I look a little bit worse, and I go. And what do I walk away with? And there are a few things that I think you get in the MDA setting that are unique and empowering. One is hope, because things are changing. When I became a neuromuscular physician, we didn't really have any blockbuster drugs, and that wasn't so long ago. And now we have 8 new, exciting, game-changing treatments for different neuromuscular disorders just in the past 4 or 5 years. 8. After decades of us crawling along, we've suddenly exploded. By coming to an MDA care center, you know you're going someplace where if something has changed for your disorder, your rare disorder, somebody's going to know about it. And that's powerful, and it means early access to novel therapies. 2, you're going to have somebody who's willing to jump on board with you, to be your cruise ship director, to be your co-partner, to be your co-pilot, and make sure that we're watching out for your lungs, we're watching out for your headaches, we're watching out for your skin and things like that. It's an advocate. And so if you haven't engaged in MDA care in a while, there are a few options. Call your local MDA office, look them up online, and see if you can get plugged in with an appointment. You can ask for engaging right away in your full MDA care center, or if you're a little bit hesitant and you're not sure if you want to jump right in again, you can even see if an option exists for just meeting with the MDA neuromuscular doctor separately, even out of the MDA clinic setting now that we've become so much more fluid and flexible in the setting of COVID, to see how it might help you. But a check-in just to see how we can help you, I think is empowering. And I'd encourage you to speak to your local MDA office and see how we can set that up.
Yeah, that makes complete sense. How about, I know someone commented too that they're actually in a nursing home facility. How do the care center doctors work with some of those that may be in some of those other settings?
In the past, pre-COVID, pre-coronavirus, patients were able to come in without a problem for their visits, and we would communicate by sending notes back and forth and thinking of the nursing home or rehabilitation facility doctors as the primary care doctor for that period of time. A lot of the lab testing and things like that wouldn't even require visits to our clinic because that could be done at the rehab or nursing care facility. In the time of COVID, we understand that transport out of inpatient facilities is a lot harder. We know that rehab facilities and nursing homes have to protect all of their patients, and we also know that it becomes a lot more onerous to leave. Telehealth is a valuable new tool that many of us are still using, and at least at this current point in time, we are allowed as clinicians to do telehealth even when somebody is not in their home setting. And so asking whoever your primary doctor is at your rehab or nursing facility to help engage in a conversation with your MDA clinician is not only reasonable, it should be an expectation. We're here to help, whether you're at home or in rehab or a nursing facility or an inpatient at our hospital or somebody else's hospital.
And I think, Dr. Delfiner, the last question that we have time for, I think, is something that we hear kind of often here at MDA too, and it's just, would you be able to share a little bit about what the difference is between why should someone go to their PCP or pediatric doctor versus the MDA neurologist or the care center?
Okay. It is never wrong to plug in both team members. But when you call in with a medical issue, sometimes I'll call you back and say, yeah, come on in, we need to see you in center. And other times I'll say, time to call Dr. Jones, and I'll help you do that. If you are a little bit on the sick side, you have a cold, you have a cough, a little bit of a fever, and you do not need to go to the emergency room, seeing your medical doctor who can evaluate for your medical safety is the appropriate thing. And they'll probably reach out to us in the MDA care center to find out about care-specific issues. So you don't want to see your neurologist to treat your pneumonia. Not the best idea. But you do want to see your medical doctor who's going to give a call to your MDA doctor, say if you have a condition called myasthenia. I'm hoping Dr. Jones is going to call me and say, I know there's some antibiotics I can't give. Can we talk about that? I see the list that you sent to me. Can we talk about it? But for general medical issues, like a rash that you might be having, allergy symptoms, a little bit of illness, call both teams. Call your MDA care center so we can know that something's going on and reach out to your doctor. But see your regular medical doctor. Or of course, if there's an urgent issue, you're having trouble breathing, you're really falling apart, you're feeling very, very weak, you just seem sick, and you're heading to the ER, it would be good to alert your primary care doctor's office and of course your care center team. Activate your emergency letter.
Perfect. I think that's wonderful advice. Dr. Delfiner, thank you so much for all of this wonderful information that you shared with the community and for all your time and effort working on this event with us. We really, truly appreciate it.